we've got Mr. Martin in the bed with us. We're going to go over abdominal assessment. Abdominal is an assessment. It is not a management. Therefore, you do not have to teach. You're only assessing. The mnemonic that we use in the most recent evidence-based mnemonic, it goes like this. It's in the back behind me, the PPPPLSLSF. And that stands for privacy, P, pain, position, and then, of course, all of the big agencies like the World Health Organization, ANA, NLN, all these people say, all the books say that you must look first. If the patient has some type of gastric suctioning, you must turn that suction off before you listen, which is the next L. And then immediately after you listen, you have to turn that suction immediately back on again. And then you palpate or feel. So it's privacy P, pain, position, look, suction off, listen, suction back on, and feel. Now, I would venture to say that out of the phone calls I've gotten back in the last 2 years, maybe 2 or 3 of my students had a patient who had some type of gastric suctioning going on. They may have had a blockage, and that they went ahead and dropped a suction, a suction tube, Salem sump or something down into the abdomen to suck off those gastric contents so that the patient doesn't fill up and aspirate. So it doesn't happen often, but it has happened before to students. So you should understand that if they have some type of gastric suctioning going on, you have to turn it off before you listen. Another thing I get asked is if I get assigned abdominal assessment and the patient is on like a PEG tube feeding or an NG tube feeding. Those are considerations that you have to have. Not only how far you lay the patient down, but also whether you turn it off or put it on pause while you're listening. Does that make sense? Because the point here is that you are going to make no sounds at all in the abdomen so you can hear the bowel sounds. Does that make sense? Okay. Now, so once again, on page 102 of the new study guide, on the very first page of the Cardex, in the very middle column, just above comfort management, you will see abdominal assessment. Now, when you look at that abdominal assessment, you'll see a line out beside of it, and that is if there are any specific circumstances, some landmark, a wound, a patch, something that the CE wants to let you know about, they'll write it out on that line. Okay? So don't worry about it. If there's writing out there and you have a question, you can ask the CE about that question. And when? Report. Say report. Somebody say report. Oh, yeah, that's right, in report. So you guys can ask in your report, what does that mean, Miss CE or Mr. CE? So that's where the assignment comes from. We good on that? Is everybody good on the mnemonic? Privacy P, pain, position, look, suction off, listen, suction back on, and feel. Now, obviously, if there's no suction, you're going to have to do look, listen, and feel. You do know that you have to do look, listen, and feel in that order, right? You can't feel first, then look, then listen. You have to look, then listen, then feel. Has to be in that order. They'll automatically fail you on the PCS for not doing it in the correct order. Okay? So I'm going to take this book right here and I'm going to set it over to the side. Now that we've got the paperwork part taken care of. Okay, so Mr. Martin, I'm going to do an abdominal assessment with you. Before we get started on this abdominal assessment, I have closed the door for your privacy. Or if it's a double room and you've got a curtain there, I've closed the curtain. Usually when you walk in the door from the get-go, you'll close the door. But remember, it's a critical element in abdominal assessment, is it not? Providing privacy is a critical element. So when you're in that box, you can't assume that everybody knows you closed the door. You have to say, I have closed the door for your privacy. Does that make sense? Good. Do you have to urinate right now?
No.
Okay, you don't have any problems?
No.
Now, if your patient had to urinate, you got to stop. You got to take them into the restroom and let them urinate. You can't go poking on their tummy if they got a bladder full of urine. You got it? So you ask them if they have to urinate. That's privacy P. Now, Mr. Martin, I'm going to be lightly palpating on your abdomen right now. Are you having any pain or any discomfort in your abdomen right now?
No.
Would you please let me know if that does happen while I'm lightly palpating?
Sure.
Privacy P, pain. Now, what's the proper position? I get asked this question all the time on the internet. Technically speaking, a patient's knees should be flexed. Can I go ahead and flex your knees a little bit more, a little bit more? Okay. So if you want to put a pillow underneath his knees right here, that's fine. But the knees should be flexed. The next thing I'm going to do is I'm going to lower you down flat. Now, he has no suction. He has no NG tube. He's not a COPD patient. He's just a no comorbidity patient. We're going to lay him flat.
Move this pillow on my back here.
I tell you what, let's go ahead and take this pillow back out right here. And technically speaking, I should have already done that. So did y'all get that? Take the pillow out behind his head before you even lay him down. That way you don't have to lean over and pull it out while he's, flat on his back, and you compromise your back. So we're going to lower him down flat. So now I've got privacy, P, pain, position. I've got him in the proper position. All right, now he's flat. So what's the next thing I'm going to do? I'm going to ask him, if you could just pull your gown up for me right here, just below right here at your little xiphoid process right here. Gentlemen, if you have a female patient in the bed, let them adjust their own clothing, okay? Just as a safety measure in an emotional jeopardy issue, you always want to make sure they adjust. You want them to pull the clothing, their pants down to just right above their hairline. So you want to get a good distance between the belly button down and the good distance between the belly button up. So you can kind of draw a horizontal line straight through the belly button and then a vertical line straight through the belly button. We're going to cordon off this abdomen in 4 quadrants. Right upper, right lower, left lower. And the first thing I'm going to do is I'm going to look. I'm going to look at his abdomen. I'm going to look to see if there's any discolorations, any scars, anything remarkable that I can see. I can even look down to see if he's obtunded or if he's distended. Now, it may be natural for him. So if there's a question that I have, I want to ask him. During my CPNE, I had a patient who had an appendectomy scar, but he also had some couple scars up here where he had a lap chole done. And I just asked him, what are those scars right there? He told me what they were, and I just charted them appropriately. Does that make sense? Didn't make a big deal out of it. I just charted it. So now that we've looked right here, the next thing that we're going to do is if he had suction on, I would reach up and turn that suction off right now. Actually, yes. Then I would go through the process of listening. I'm trying to think about all the little nuances here. Try to teach you everything at one time. So now I'm going to start in his right lower quadrant. That's the most appropriate place to start. It's the most evidence-based place to start is the right lower quadrant. That's the ileocecal connection. That's where the small intestine and the large intestine connect. That's actually where you have the most active bowel sounds also in your digestive system. So start right there, the right lower quadrant, and then work your way clockwise around. Right lower, right upper, left lower. You're going to take the stethoscope, you're going to sit, and you're going to rest it on the skin, press downward, and you're going to listen. Now, if Sherry was sitting over there right in front of me right now, the CE, if she was over there listening with me, as I'm listening for about 10 to 15 seconds. Okay? And I'm just listening to make sure that I've got bowel sounds there. To make sure that they're present. Now, when I feel like they're present, I look up at the CE, I shake my head yes. Then I go to the next quadrant, listen there for 10 to 15 seconds. Making sure that I have bowel sounds. Making sure that I press the stethoscope far enough onto the skin to completely have the whole entire bell of the stethoscope in contact with the skin. Do not put it on the ribs up here. If you've got a pediatric patient and you do an abdominal assessment, remember your area is much smaller. So do not place the stethoscope on the patient's ribs. So I'm listening for 10 to 15 seconds up here in this right upper quadrant. Let me put this thing on so I can look official. I heard it immediately. So I'm good. I've heard about 3 or 4 bowel sounds in that 15-second period. I look at the CE, shake my head, go to the next side. And now I'm in the left upper quadrant. Shake my head, yes. Come down to the left lower. Okay. So I actually had, he has very good bowel sounds. They were present in all 4 quadrants. Now, it begs a question now, because there's some things, some differences, or there's some situations going on out on the internet about how long you listen. If you don't hear bowel sounds in 15 to 20 seconds, you probably need to look at the CE and say, I'm going to listen for a full minute. If you make the clinical decision to listen for a full minute, you tell the CE you're going to listen for a full minute, do you think you need to listen for a full minute? You need to listen for a full minute. And once you make the decision to listen for a full minute, you got to refer to your watch then. So if you don't hear anything with that first 15 to 20 seconds, you thinking, I'm concerned about the bowel sounds maybe being very slow or absent, I'm going to listen for a full minute. Okay? Okay, so I'm going to get to that part right there in just a second. Okay, so you can listen for that full minute. If you don't hear anything within that first full minute, Excelsior is saying on their videos, correct? On their videos, they're telling you to listen for 5 minutes in that quadrant. That's a long time. Okay? We're going to recommend that you stay to that standard. If you do not hear anything, you're going to need to make the clinical decision to listen for 5 full minutes in that particular quadrant. Just because you decide to do that in one quadrant does not necessarily mean you have to do it in the other quadrants. Okay? So just keep that in mind. Each quadrant is individual, and if you make the decision, you make the decision individually if you're going to listen for that full quadrant. If you listen to it, if you say I'm going to listen for a full minute, and then you hear something first 10 or 15 seconds, and you start hearing them, they start picking back up again, when you're finished with that first minute, you're good. But if you continue not to hear anything, you're going to have to listen for 5 minutes. Okay, and that's just according to Excelsior. Yes, ma'am. No, because Excelsior has set the policy. It's just like there are other things that you may think, like holding pressure after you give insulin. You may think that that's not a good thing. Well, Excelsior says if you give a subcutaneous injection, you apply light pressure. They don't delineate anything other than that. So they have set the standard when they say 5 minutes. Okay? So the only issue I have with it is because it's not in the study guide. There's nowhere in the study guide that says you have to listen for 5 minutes. You have to watch an EC video to get that information. So that kind of, once again, that's my full disclosure type of an issue that I have with it. So keep that in mind. So we've looked, we've listened, now we're going to lightly palpate in each abdominal quadrant. What are we feeling for? Hardness, any rigidity, tightness, point tenderness. So I'm just going to lightly palpate. And I'm just kind of putting my hands down like this right here. I'm not doing anything like that. I'm not doing ballottement or anything. I think that's called ballottement. On babies, where you push from one side to the other. Any pain?
No.
Any issues?
No.
It feels nice and soft and tender, nice and pliable down there. So now we're finished with our abdominal assessment. Before you get back up again, I'm going to go over here and look at my grid real quick and just make sure I did everything. So I'm going to walk over to my grid. I may get a little shot of gel. And then we're going to raise you back up again. So I've checked my grid. I've done everything. Privacy P, pain position, suction off. Look, listen, and feel. Everything is good. Now, to be honest with you, if you're really on top of your game, if you've practiced this, this is like a 2-minute, maybe a 3-minute assessment. The assessments are very quick. But it's all going to be determined by you and how much you practice when you go home. Okay? Now, are there any questions about the abdominal assessment? Bowel sounds are present or active. Now, you could, if you wanted to, put a numeric value on them. Usually what I do is I'll take 15 seconds worth of bowel sounds, I'll multiply it times 4, and I'll come up with a total number. Now, you ready for this? You want to get your pencils out here. So, the books say that 0 is 0, therefore those bowel sounds are absent. From 1 to 4 a minute, if you have 1 to 4 bowel sounds a minute, that's considered hypoactive. If you have roughly between 5 and 34 or 35 a minute, that's normoactive. And if you can count 36 or above, it's hyperactive bowel sounds. Okay? If you want to do it that way, you can. My only issue with doing bowel sounds that way, and of course, I'm just telling you what the books say. The books don't tell you how to count them when they go brrrr. Anybody ever listen to bowel sounds and they do that right there? So it's just like bam, 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 bam. It's like you having to count these things. So, yeah, I kind of have a little bit of an issue about it. I like they're either active or they're absent. I like using simple terms when you're under a lot of stress. But if you can clear your mind and you can count like that, then you can go ahead and add a numeric value to it. To just make sure that if you do add a numeric value to it and you get questioned, well, how did you determine that was normoactive, or how did you determine that was hyperactive? You just tell them what I just told you. 1 to 4 is hypo. 5 to 35 is normo. Over 35 is hyper. You can tell them things like that. So just remember that they can ask you questions for clarification as to what you document. Does that make sense? So that's abdominal assessment. It's not hard. I probably make it overly hard by explaining it, but the reason I explain it so extensively is because I know what your questions are going to be to me. I know what you're going to ask me. Well, Greg, what about this? And Greg, what about that? So I just go ahead and take a little bit of extra time to try to answer those questions up front. Obviously, when you're on the internet doing the online workshop, you just type a question in there, and then I will get it, and I will try my best to answer that question for you in the online workshop. Okay? So that's abdominal assessment.